Yes, my name is Charles Young. I'm from a company called SolSoft Reply. I was quite delighted actually to hear in the first presentation the comments about the lack of electronic support for registers. So we've been working for some time with Calderdale and Huddersfield Foundation Trust to build a controlled drug register system that effectively deals with a number of different issues. If we just go to the first slide, and I'll just I was slightly out of sync there, but that's just my name down at the bottom. This I'll introduce in just a moment. And if we could just go to the next slide, perhaps. So very, very simply, it is true that most trusts currently are still using paper-based systems, both for registers and also for CD orders. And it is a very paper-based system in most situations. The law was changed well over 15 years ago to make it clear that electronic systems are acceptable, but it's taken a long time for electronic systems to really make their advent. That's beginning to change. And the benefits of paper systems, of electronic systems over paper systems, are reasonably obvious. The kind of issues with paper is obviously the storage of paper everywhere within a complex environment such as an NHS acute trust. The fact that things are handwritten and difficult to read, all the maintenance of the registers, the carrying forward of balances, the mental mathematics that's actually required. Illegible handwriting and crossings out which go on in the real world. So these are a number of issues which really do cost a lot of time and effort as far as clinicians are concerned. If perhaps we just go on to the next slide. So we've been working on a system called eCDR Pro. And it is a replacement for both the CD ordering that happens in a trust, an acute or mental health trust, between wards and the central pharmacy, and dealing with the ordering of general stock, which is kept on the wards, and also stock for named patients, for specific patients, and also well, in terms of ordering, dealing with that, but also dealing with the registers which are maintained on the wards in particular, and also in the pharmacy. And that's obviously a register for general medicines, and also typically a separate registers for patients' own CDs, the controlled drugs they bring with them, and various other aspects of the whole thing. So basically providing an electronic approach to managing that, looking for every opportunity we can to eliminate common sources of error, to reduce the amount of time, particularly in terms of the checking and chasing down on errors and problems which arise, and trying to both eliminate those, make it easy to find out what's happened when something has gone wrong. Obviously used by clinicians, very busy people in very pressurized situations. So a lot of emphasis on the ease of use and ensuring that there is a real view both within wards and across the trust of the stock holdings of what's actually happening, what the state of those CDs currently are. The last point on there is just about the fact that we're a kind of modern application based on the cloud. If we just go on to the next slide. So essentially, eCDR Pro was written specifically for an acute trust, and with a view to using that in other trusts as well. It's a pretty good fit with mental health trusts as well. It is not designed for community pharmacies. It is designed to address the complex landscape that we have in trusts up and down the country. And that means dealing with many safe custody locations. Typically, we're dealing, I think, in the Isle of Wight, I think there are 6 wards, I think, in total, if I remember rightly. But elsewhere, you know, it's typically maybe 80 locations, 120 locations, something like that, where CDs are kept across that. So we need to deal with that and ensure that we deal with the complexities around that. It's been very much co-designed with clinicians and checked very thoroughly from a clinical safety point of view in compliance with the law. and also a system that can support integration with other systems. We haven't done very much of that yet, but it can support integration with other systems. So I want to stop there, just as a brief introduction, and hand over to Lis Street, who's with us. I think Liz is probably known to a number of people on the call. She's the Clinical Director of Pharmacy and CDAO from Calderdale and Huddersfield. And I'll hand over to Liz.
Thanks, Charles, and thanks for inviting us today. So it's just to give a bit of my take on it, really. I'm sure it'll probably be a similar story to a lot of yourselves involved in CD management. I work at Calderdale and Huddersfield Trust. I've been here 4 years now as the clinical director, and I've also got the CDAO role for the joys that brings. We've, pre my time, we'd had a couple of CQC inspections, both of which highlighted potential issues with CD management, documentation, the old crossings out, and looking at our CD rec order books for the nurses to order their CDs from pharmacy, supposed to be signed off by ward managers. So again, the CQC picked up similar themes, that they hadn't been signed off and hadn't been authorised. Theatres had perfectly aligned bookings out and documented witnessing of their doses they'd given, and when we looked at it, they were all so perfectly aligned. It started asking questions: were we just signing at the end of the list and not after each patient as we'd like? So CQC showed we've got issues. We do biannual pharmacy CD audits out on all the wards, and again, it was showing us exactly the same themes, and it felt a bit, no matter how much we reviewed our meds policy and CD policy, that was correct, how much training and induction we did and revised how we did that, medicines management newsletters coming out of our ears highlighting these issues, but it still wasn't making any improvements. I think COVID probably really sort of made us focus on how to do things better. We knew that from red areas like our ICUs, it was not ideal bringing paperwork out of ICU to order a CD, carrying it many floors down to pharmacy for them once to then carry the book back up. And again, the sort of IPC risks that involved, never mind the sort of nurse time spent physically walking up and down a sort of a full-story hospital. So it was a bit about thinking, what can we do differently? I suppose my other concern is our audits themselves. I've got pharmacy team members go out, audit wards, come back with lots of bits of paper that get scanned in, emailed off to matrons, emailed off to ward managers. I try and have a look at them, but it was it was a very paper intense process. We're a very digitally thinking trust. We've got EPR, which we've got interfaces with our own pharmacy system with EPR, and it just felt like this was sort of this quite clunky paper-driven system that we were all used to and very comfortable with, but at the same time, how could we do it differently? What I wanted to do is enable us to free up nursing time, avoid the crossings out in the registers that no matter how we tried, just kept appearing. And for me to have a better, with my CDAO role, to have a better oversight of wards and areas that were really sort of struggling and our areas of concern. And if you asked me today, because we haven't quite gone live yet, which of my wards and areas of concern, I'd have to go through a load of paperwork to sort of go back and check audit results to be able to tell you that. I looked at what was out there in terms of electronic systems, and the sort of ones I'd seen were very much community pharmacy related, which didn't solve the problems we had with patients bringing in their own patients' own controlled drugs, transfer between wards when patients move wards and need the drugs going with them. Recording part doses, again, it didn't give us that functionality from the electronic systems I saw. Illicit drugs management was another one that we needed to solve and make sure we've got a really robust solution. And I guess from a nursing time-saving perspective, to be able to order electronically directly from the ward without having to bring bits of paper down. So we started to design our own, which was a bit of a scary world for myself, my MSO, our meds management nurse, and members of the pharmacy team. But interesting journey working with a software company, talking about wireframes and sandpits. I thought we have a load of technical jargon, but that's nothing, I think, compared to Charles and the team. It's been a long journey, but I think we've been trying to make sure we get all the functionality we need, so that when the system is fully up and running, it does everything we need it to do, rather than trying to look for add-ons and developments in the future. So we're at the exciting point now. We've done the user acceptor testing. Again, the NSO has been integral in developing this system, literally testing it every step of the way. And so it's not a solution that was presented to us, it's one we've worked with to make sure it's fit for purpose. So we've got 2 hospitals. We're about to go live at Huddersfield first in pharmacy and out in one of our surgical wards, hopefully within the next week. So very exciting times, and then roll it out across the whole organisation. So yeah, where do I want to get to with it? I want CQC to come in and love it, that we have no more crossings out. We've got mandatory fields to be filled in for second checks, so they can't get missed. We can make sure in our theatres that nobody's doing it, putting all the entries in all within 2 minutes after 3 hours of not entering a single thing in there, so we'll be able to tell that they're doing what they should be doing. And again, massively because of the pressure on our nursing workforce, really freeing up their time, so it's not spent wandering around the hospital with CD books. They can be focused on looking after patients. And that's it, hopefully. Thanks.